Hello, welcome to the Community Engagement and Research Facebook Live Chat about uterine fibroids. I'm Dr. Joyce Ballsbury, Assistant Professor of Epidemiology and one of the founders of the Mayo Clinic Office for Community Engagement and Research. Today, we have Dr. Elizabeth Evie Stewart, a reproductive endocrinologist and gynecologist from Mayo Clinic. We are going to learn a bit about how Dr. Stewart became interested in her field. We're also going to chat a bit about the topic of interest for many women, which is uterine fibroids. Dr. Stewart, thank you so much for joining me today.
Oh, it's my pleasure. I always love to talk about uterine fibroids. Thanks for the invitation.
So we would like the audience to learn a bit about you and your work at Mayo Clinic and how you became interested in obstetrics and gynecology.
I always liked the field of obstetrics and gynecology. It's a wonderful field to take care of young women and to help them get to their goals of family and health. And during my residency training, I did a lot of surgical gynecology. When I started my fellowship in infertility medicine, what we call reproductive endocrinology, I started doing basic research in fibroids. So I worked in the lab trying to understand something about the basic biology. And I've really continued that over the last 25 years. And now I'm doing more clinical research on how fibroids affect women and how we can get better treatments for them.
Wonderful, wonderful. I know that you've helped several women increase their opportunities for reproductive health. And I know that you've also really had been in the forefront of helping women find out ways to treat and do symptom management with uterine fibroids. Would you share with the audience a little bit about what uterine fibroids are? And I think we have an image that we can show.
Perfect. We can start with the diagram that uterine fibroids form in the uterus. And the uterus is normally a pretty small organ, about the size of your fist. And the fibroid is sort of like a knot of muscle that they can begin with a single cell and grow. And the picture shows several different fibroids. It shows a submucosal fibroid, or one that's intruding into the inside of the uterus. And actually in this picture, there's one that's mainly in the wall but intruding, that's labeled submucous fibroid. And then there's a pedunculated fibroid that's kind of hanging in the middle of the uterus. And those kind of fibroids tend to give women both heavy menstrual bleeding, and they tend to give women problems getting pregnant and carrying a pregnancy safely to delivery. You can also have fibroids in the wall, the intramural fibroid, and then a fibroid that's protruding from the outside of the uterus that makes it kind of feel lumpy and bumpy, what we call a subserosal fibroid. Now, the interesting thing about this diagram is it really shows pretty small fibroids. And fibroids can grow so that they can be much larger than the normal uterus. So it's not uncommon to get a fibroid that's the size of a grapefruit or even a basketball. And it's not unusual to have 25 to 50 fibroids instead of just one or two. So that really gives you a sense of the range of disease.
Wow, that's interesting. So what are some of the common symptoms for fibroids? I know you mentioned heavy menstrual periods, but what are some other symptoms that women might notice?
Well, it's worth talking for a minute about the heavy menstrual bleeding because a normal menstrual period usually lasts about 5 days. And so women with fibroids can often have fibroids that last 10 to 14 days. And even women that don't have long periods can have such heavy periods that it affects their ability to work or go to school or care for their family. And heavy menstrual bleeding can lead to severe anemia and sometimes even transfusion. It's not unusual for a woman with fibroids to end up in the emergency room and need a transfusion. But you're right, there are other categories of symptoms, and fibroids can press on the bladder, giving you urgency of urination, frequency, getting up at night. It can press on the bowel so that you have constipation or problems with bowel movements. They can protrude from the abdomen, so women look pregnant when they're not. And that's really a problem for a lot of women, not only because of the way their clothes fit and their self-esteem, but fibroids can sometimes, but not always, impair their chance of getting pregnant. And so specifically for the woman who wants to be pregnant and the fibroids are causing a problem, and yet they're looking pregnant and getting comments from people, it can really be a problem.
Thank you so much for your response. One of the other things that we've talked about when we think about the symptoms and symptoms management is the apprehension sometimes that women might have of talking to their healthcare provider about sensitive topics like uterine fibroids, heavy bleeding, and even things like incontinence and constipation related to their fibroids. What advice would you give them in terms of starting that dialogue with their healthcare provider?
I think that's a great question because sometimes it's difficult to not only talk to a professional, but sometimes to talk to your family. And there's some new evidence that suggests that even some women go to their friends and their family and say, I'm having this problem of having 10-day periods. And they're told, oh, that's normal. It happens to me too. So the first thing is to feel comfortable talking about it. In this country, we can talk about many uncomfortable things, and that the airwaves are full of discussions and ads for products for erectile dysfunction, that it's possible to talk about sensitive topics. And I think going into a conversation with your healthcare provider with some knowledge is helpful. So to be able to say, gee, I'm having heavier periods. Do you think this could be uterine fibroids? Okay. Or I'm having trouble having my clothes fit. Do you think I could have a uterine fibroid? So I think, again, knowledge empowers women to be able to ask those questions. And certainly they shouldn't be embarrassed. I think healthcare professionals are used to discussing things like heavy menstrual periods or problems with sex because of the fibroids.
Interesting. So there are some treatment options for uterine fibroids, and one of the most common ones that's usually done with a lot of women, and I know especially even with women of color, is hysterectomy. Can you go a little bit into detail about hysterectomy as well?
Yeah. So hysterectomy is the most common treatment for uterine fibroids. Of all the fibroid treatments, it occupies about 75% of all fibroids.
Really?
Absolutely. And in fact, there are many more hysterectomies done for fibroids than all kinds of gynecologic cancers combined. So fibroids and abnormal uterine bleeding account for about half of all hysterectomies in the United States. And when you take uterine cancer, cervical cancer, ovarian cancer, breast cancer combined, that only accounts for about 8% of all cancers. So it's a huge part of the reason women undergo hysterectomy. And hysterectomy can be a good solution for uterine fibroids. It not only treats the fibroids that are there, but it eliminates the possibility of new fibroids forming. And sometimes women can have 2 or 3 reasons to have a hysterectomy. They can have uterine fibroids plus precancerous changes of the cervix. They can have uterine fibroids plus a different disease called adenomyosis. So the nice thing about a hysterectomy is that it can treat multiple problems all at once. But there's a huge body of literature that's showing that there are downsides to hysterectomy. So again, the literature suggests that women's quality of life is improved for 5 to 10 years following their hysterectomy. But we and others are showing that 10 to 20 to 30 years down the road, that there may be increases in heart disease, there may be increases in other diseases that are important. And some of that focuses on whether or not you have your ovaries removed at the same time, because the ovaries are what make the female hormones, estrogen and progesterone. But increasingly, there's evidence that even if you leave the ovaries, there can be long-term problems. So hysterectomy can be a solution for many women, but particularly for younger women and absolutely for women who still want to have children, saying, what are my alternatives to hysterectomy is really important.
So for women that want to preserve their uterus, what are some of the options that they have and that are on the forefront?
Okay, so there are surgeries that conserve the uterus, and some of those have been available for 100 years. Some of those have been available for about 25 years. They're called myomectomies. So they can remove the fibroids and repair the uterus. So sometimes the fibroids are big enough they have to be removed through an abdominal incision like you do for a C-section. And sometimes the fibroids now can be taken out with telescopes. So you can put a telescope in the abdomen and remove fibroids through a laparoscopic or robotic myomectomy. And sometimes you can even put a telescope on the inside of the uterus and remove a fibroid that way. So there has to be careful decision making about the size of the fibroid, the number of the fibroids, the locations, but many women have those options. And again, particularly for women who want to have children, that it is a procedure that can be done as safely as hysterectomy.
So I know that that there's some talk about focused ultrasound as a good treatment option for certain types of fibroids, and we might even have an image of that as well. Can you talk a little bit about focused ultrasound since it's so new?
Yeah, so focused ultrasound is one of the treatment options that we've been working with since about the year 2000. It was FDA approved in 2004, but it's unfortunately still not widely available throughout the country and through the world. It's the first non-invasive treatment for uterine fibroids. So as the image shows you, the treatment itself takes place inside an MRI machine. And that guides the therapy and also uses temperature to tell you when the treatment is complete. It's ultrasound waves that actually go through the abdominal wall and into the fibroid that destroy the fibroid. And so each fibroid is targeted individually. So again, it makes a difference how big the fibroid is, where it is, even what its appearance is on imaging. So certain fibroids soak up the energy better than others. So again, this is an FDA-approved treatment for women in the United States. There are some newer devices that are available outside the U.S., and in fact, there was a recent approval in Europe of a device that uses ultrasound-guided focused ultrasound. So I think that there's going to be more and more of these non-invasive or minimally invasive treatment options that are available.
So we talked a little bit, and you mentioned earlier that many times women can even have the conversations with their family and friends about fibroids. Sometimes there are times when stigma happens as it relates to that, and even fear of treatment. So what is some of your advice for reducing stigma around fibroids?
Well, I think the first thing is to feel comfortable discussing it. Again, some women and some families say, we don't like to talk about things like this. But it's a critical disease for women and has a major impact on women's function. We've done some nationwide surveys that show that fibroids interfere with the ability to work. They interfere with relationships. They interfere with pursuing the kind of career you want. And in fact, some of these concerns are more significant for African American women. I think we talked a little bit before about African American women and fibroids. And African American women develop fibroids at an earlier age. tend to have more severe disease, tend to have more anemia, so they have more impairment for this disease. And so it's really important for African American women to be able to say, gee, something's not right. Could this be fibroids?
Do you think that that might have some familial impact as well, like hereditary, if their mothers may have had it or grandmothers?
Yeah. So there is evidence that fibroids can run in families. So if your mom had fibroids and your aunt had fibroids and your cousins have fibroids, you're more likely to have fibroids. There's some interesting new work in genetics that looks at genetic subgroups of fibroids. And that, in fact, there's one gene that appears to be found in about 70% of all fibroids. But interestingly, it's found at about the same frequency in all kinds of populations. So it doesn't appear that genes alone explain the severe health disparities that Black women have with fibroids.
Okay. I know that we're starting to get some questions.
Great.
From the audience as well. And so one of the questions that just came up is, what are the pros and cons of leaving the cervix in place instead of removing during a hysterectomy?
Okay, so that's a great question. So again, hysterectomy removes the uterus, but can leave the ovaries behind. So again, unless there's a specific reason for women with fibroids, generally we'd recommend keeping the ovaries. But the cervix is the lower part of the uterus. Mm-hmm. And we don't have a picture available to show here, but we'll link to it so that people can look at it a little bit later. And there's no dividing line between the cervix and the uterus. The cervix is the part of the uterus that goes into the vagina. And in many parts of the world, the tradition is to leave the cervix and only remove the top part of the uterus. We thought that would give women better pelvic support, better sexual function, and the studies haven't shown that that's a big effect. Mm-hmm. And additionally, women who keep their cervix may have more problems with bleeding after the hysterectomy.
Interesting.
And certainly we know that fibroids can develop in the cervix. So I think it's still a question that women can discuss with their doctors. Mm-hmm. And some women still feel strongly about keeping their cervix. But the research hasn't shown it's as important as we might have thought 10 or 15 years ago.
So we have another question. Are there studies showing that the prolonged treatment reduce the fibroids?
I'm not sure what the question is referring to in terms of prolonged treatment.
So if we think about maybe, just exploring the topic of a myomectomy, mm-hmm. So if prolonged treatments with a myomectomy, would that help the patient a bit, or would the fibroids potentially return?
Well, I think with all of the therapies except hysterectomy, there's always the potential to have a new fibroid develop. Okay. So I think that that's a limitation of uterine-sparing therapies. But again, preserving the uterus can be such an important goal for many women that will accept that risk. Mm-hmm. I think the real issue is that you shouldn't be moving in the direction of fibroid therapies just because the fibroids are there. I think that they have to be causing you problems. And so again, if you have a fibroid that's identified when you're 25, but it's not causing you any problems, then it may be worthwhile waiting until it does give you problems, because if you have it out at 25 and you don't have symptoms, maybe you have a new one by the time you turn 30 when you're trying to get pregnant. So you really have to be thinking, why am I doing something about this fibroid, and what is the best thing to do?
So one of the things that you and I have talked about a little bit, offline, mm-hmm. was complementary and alternative treatments.
Yep.
Can you give a little bit of advice to the audience today about that
Yeah.
well.
So I think alternative and complementary treatments are critically important to study for uterine fibroids. There are a lot of therapies that are advertised or sold as being effective for fibroid, but with rare exceptions that there's no data to back that up. That there's some data to suggest that certain Chinese herbal medicine may be effective, but I think many women are spending their money on treatments that don't have any proven efficacy.
Okay.
And so it can also then delay them from getting effective therapy. So I think from the research community, I'd like to see us doing more research and testing out some of these pills or procedures. But I think women also have to look beyond the advertising and say, tell me, what happens with this treatment? Can you show me that my menstrual bleeding will improve? Can you show me that this will shrink my fibroids?
Interesting. So one of the things that we wanted to go to now is really thinking about some of the best resources for information on uterine fibroids. What would be some of your suggestions?
Well, I think there are a lot of great sources of information. So I think mayoclinic.org has some patient-friendly information about fibroids and even some videos and images that will help explain procedures. One of the big research projects that we're a part of has a comprehensive website, and it's compare-uf.org, because Compare-UF is a 9-site study throughout the United States to do comparative effectiveness research. The American College of Obstetricians and Gynecologists has a nice website, so acog.org. And then we also have a Twitter feed at Mayo Fibroids that tries to disseminate ongoing research on uterine fibroids. So those are a couple of places to start.
So is there anything that you're really excited about in terms of new research on fibroids?
Yeah, there's a lot of things I'm excited. First of all, I'm excited that there are more people doing research. I think having more people coming to the field is important. I think that genetics is an important new field. That again, we always knew that family history was important, but now it appears there may be 4 different genetic subgroups. And if we can try to understand how those genetic subgroups link to effective treatment. So if you have subtype A, is uterine artery embolization better for you? And subtype B, maybe myomectomy is better for you. We need to move from genetics to clinical treatment. I think there's also a lot of exciting research about extracellular matrix. So we call fibroids because they're tough and have a lot of stuff sticking the cells together. And that appears to be an important part of the biology. So I think that that's important. And I think also the clinical research that's being done that's asking women about fibroids and finding out why women put up with some of the symptoms that they have without seeking therapy, how we can educate women better about their options and empower them to seek treatment.
So we have another Facebook question.
Great.
And this person said they were a bit late joining the conversation, and they'd like for you to recap a little bit about some of the treatment options.
Okay, so there are both medical and surgical or interventional treatment options. So we didn't talk about medical treatment options before, but for women who have heavy menstrual bleeding, sometimes things like birth control pills can be helpful. There's a medicated IUD called a levonorgestrel IUD that can be helpful. There's a drug that you can take just during your periods called tranexamic acid that can be useful for medical treatment. There are drugs that actually shut down the reproductive system called GnRH agonists, and although they're very powerful, they don't have long-lasting effects, so they're usually used in special cases. And there are new drugs being developed that aren't available in the U.S. yet, but probably will be in the next couple of years, called progesterone receptor modulators. So there are a good deal of medical therapies that can be helpful. Again, with surgical or interventional therapies, we have hysterectomy, which removes the uterus and prevents recurrence, but may have long-term effects that we're just beginning to appreciate. We can have surgical myomectomies. There's a treatment called uterine artery embolization, where it's a quick procedure that's usually associated with an overnight hospitalization that cuts off the blood supply to the uterus and is a very effective treatment option. And there are some newer devices that are also used for fibroids. So there's a procedure that uses a special kind of energy called radiofrequency ablation to zap the fibroids during surgery. And focused ultrasound does something similar with ultrasound waves.
So one of the other questions that I have before we finish is, what is the typical recovery time for some of the minimally invasive procedures?
Yeah, so that's a great question. So some recent work we published suggests that probably the shortest recovery period is for focused ultrasound surgery. Usually women are back to work in 2 to 4 days.
Oh, wow.
Uterine artery embolization is slightly longer. So again, an average of about a week, but up to 2 weeks for that. Some of the minimally invasive surgeries, like a hysteroscopic myomectomy, can be in that range. And surgeries like myomectomies, when they're done with a robot or with a laparoscope, are usually in the range of 2 weeks. But more extensive surgeries through an abdominal incision, we're talking more like 6 weeks. So there's a huge range.
Okay. So I wanted to ask you, well, first of all, thank you for coming.
My pleasure.
There anything else you would like to share with the audience today before we conclude?
I would just encourage women to feel comfortable talking about this disease, talking to other women, seeing what their experience is, not feeling inhibited by going to their annual exam or their checkup to say, I'm having these new symptoms and I've read about uterine fibroids. Could this be causing my problems? And also to not be afraid to seek a second opinion if, you're told, nope, that's normal, you need to live with that, or no, the only option for you is hysterectomy. I think women have more choices in this day and age, and I'd like to empower them to try to find them.
Great. So we really appreciate your time today, and to our audience, thank you for joining us, and please check out the Office for Community Engagement and Research, and I also like to thank the Office of Women's Health and the Department of Social Media for supporting this Facebook Live feed today. If you have additional questions, please follow us on Twitter at Mayo Fibroids. And also, we will provide some additional information and links to other resources in the comment section of the Facebook Live feed. Thank you so much. Have a great day. Bye-bye.
Thank you.